Okay, thanks to Elizabeth McCauley for kicking off our discussion on what we should all be spending more time thinking about in depression research.
How do I go forward? Sorry, I didn't even mean to show this one.
This
Goes
arrow
me
got
forward.
rubbed
Thanks.
off.
So thank you very much for inviting me. I'm going to take you on a very different pathway than the other two speakers, but I think we could all come up in a bit and talk a little bit about what this means. And my goal is to get you thinking about, one, the importance of your work, which I really would complement what we're learning from developmental psychopathology writ large, and also what we need in the real world to learn from the work that you're doing. So I think there's certain assumptions that I'd like to put out there. And one assumption is based on my reading of the data, and I don't think I'm alone on that, that we have data that's suggesting that we really, in the clinical realm, need to move from a categorical diagnostic kind of framework to dimensional thinking. I think this isn't rocket science to you all. You all are probably long there. But I can tell you that our billing codes, our clinical practices, who gets services and who doesn't get services, they are not there at all. I think that we also need to be rethinking about how we think about, talk about, work around these issues of psychopathology, that instead of symptoms, I think we are being urged from the findings of the developmental psychopathology work to think about common elements, traits, for example, emotion regulation, impulsivity, disordered thinking, that contribute to a multiple of diverse conditions, and that is ergo why we have so much comorbidity. We're not thinking of discrete buckets or a depressed child here, an ADHD child here, an antisocial child here, but they're all kind of have some of the same underlying characteristics that are expressed in different ways, possibly in different points in time in their development. And we know that these traits are shaped by the environment and multiple environmental influences. I don't mean to rule out the biological components of the environmental influences as well, but we know that stress is huge, parenting, abuse, these are all huge factors that come together to interact with these underlying traits and lead to some individuals expressing functional impairments. I'm trying very hard, and it isn't easy to step away from the regular, the typical, the language we first learned to talk about psychopathology, because I think what we're learning from the research done by many of you is that we need to think differently about this. But we have a huge challenge. Our timing is a little bit off. We have a huge challenge, and we have a dramatic increase in clinical demand. And I can speak to this, and I am here to give a plea to you because I work in a clinical setting. In the month of May, we saw 400 kids in our emergency room. I'm here now, and there are probably 9 kids boarding in some place in the hospital waiting for some kind of services. We are having this dramatic increase in the need to intervene around depression and suicidality. So if we just think about suicidality, and there's different sources of data, and we could argue that, and we probably do need to argue that, but just to give you an example, there's reports of 50% increase in suicidality among girls. These are all within the last 5 to 10 years, a 30% increase for boys. And whether we question those data or we embrace those data, if you're in a clinical setting, you are dealing every day with that phenomenon. I'm not sure where it comes from. So what we need, all of you in your work, as you're doing your work and what you're thinking about, we need guidance about how do we do this how do we engage in the clinical work that we're doing? Do we change our classification systems? I think there is kind of clear movement on that to go from categorical to continuous. But also, what does it say about our intervention models? We need guidance about how we're going to be intervening. Are we going to go with an illness approach, or are we going to go with more of an adaptation, normalization kind of approach as we think about mental illness and behavioral developmental challenges? How do we talk and think about these things? How do we present these to the public to make our interventions more welcoming, more palatable? Where do we work? We need guidance about where do we work? Is all our work done in integrated care settings so that we're not separating ourselves out into clinical settings that are not integrated into primary care, our specialty care, pediatric work? How much are we working in schools? Is that where we really need to put our money, our dollar, our time to be doing our work in schools and step away from traditional clinical models? But the other option is to think about, let's put all our money, all our bucks, all our energy into community-wide education and prevention programs, touching people as early as possible, working a lot with families, early intervention, early prevention. We need guidance. We need to know the dollars are limited, and we need guidance about where we're going. I think the other question that we need guidance about is, what do we treat? Do we treat functional impairments, thinking about a John Weiss kind of top problems model? Do we try to treat traits? And traits could be broad concepts like negative activity, affectivity, emotion regulation, impulsivity. I think we do some treating of that, but what's going to be our treatment target? What do we focus on? Do we treat key symptoms? So there's some very interesting emerging work on these cascading models that say in our sample, we identify some key symptoms and we target our intervention, sometimes brief intervention, on that key symptom with the hope that it will cascade down and change other symptoms associated with depression. We also could be treating what we do now, treating ADHD as a kind of a construct, treating anxiety, treating depression as a broader concept, or do we tease out certain symptoms from that? Who do we treat is another factor we need research to guide. In the depression world, we focus very much on treating the patient over the years, and early work with parents suggested it wasn't very additive. I think more recent work would counter that, but should we be just treating parents? Is that where we should really focus? If you think about the kids that we see in the emergency room, I think there's a big argument that could be made that treating parents is going to be a key factor, and because people are struggling with how to manage these presentations. Do we treat community systems? Do we try to, again, move out to the community? And then how do we treat people? We have in our field, and I think it's something we have to be very proud of and should be very proud of, that in over the last 15, 20 years, we have developed very effective manualized interventions for a number of the key problem areas that we see in child and adolescent psychopathology. So we have strategies. We know they work. Our challenge now is access, people learning all those different approaches, and length of treatment. Many kids don't have access to that kind of care. So should we use those wonderful manualized interventions that I think we're training people to do well in graduate school, or do we go to more of a common elements approach, or we're looking at transdiagnostic approaches? I think the field is evolving, and I think that it's an exciting time, but we need more research data to help inform which way we go. And then what kind of change is needed? I think this is a big factor that we clinically haven't paid much attention to, is how do we define and measure change? We've talked a lot about different approaches to measurement, different approaches to statistical analyses, but I think we need, again, more guidance about what does it mean if we're in the direct service or working in a clinical or school-based setting? what is clinically significant change? Do we need to, is that where we should be focused? Should we be focused on making smaller changes with larger groups of youth, or should we be focused on really the kind of clinical standard, the gold standard of a clinically significant change? Should we be looking at symptom reduction, or should we be looking at functional improvement? And then how do we address access? And so one of the things is, can we be looking at, we have smart models where we can look at, take an intervention, do an intervention. For those who don't respond to that intervention, they can carry on kind of in a step care model and add on another intervention. We have some nice therapeutic and research models that I think would be important for us. We need more help from you all to figure out how do we address access. So I just wanted to talk a little bit about where do we stand now regarding treatment of suicidality and depression. And I'm saying this with humility. I think there are people in the room who might disagree with me, and that's great. That would be good to hear. I would feel like in my current situation, my current mindset, I feel like around suicidality, we are actually in a little bit of a more promising place than we are for depression. I think we have the emergence of some promising treatments, not totally, we haven't solved that problem in terms of treatment. But dialectical behavioral therapy, cognitive behavioral therapy, and mentalization are all showing some promising outcomes. And I just want to talk a little bit about the lessons that we learned from our study using DBT versus supportive therapy. And Jenny's here as one of my collaborators, so it's great to have you here. Some of the things that we learned, one of the things that we learned was super, super humbling. Which is that we need to be considering a more chronic care approach, because the persistence of suicidality in this sample of 173 highly suicidal adolescents was a bit staggering. We made headway, we made progress with certainly a subgroup of kids, but we didn't cross the finish line in terms of reducing persistent suicidality for many, many of the youth. We also had some interesting findings in terms of the targets that were associated with enhanced outcomes. So DBT, as most of you probably know, is very focused on emotion regulation, and emotion regulation changes in improvements in emotion regulation came through clearly as an important factor. Other factors that came through, one was sleep, which we didn't target, but thanks to Joe Nasarno and Jenny, we ended up looking at sleep, and that became another significant factor. Interventions that focused on increasing quality of sleep. And then finally, and just to underscore, the parent part was absolutely essential. The parent training, the parent engagement seemed to be absolutely essential. For depression, and I'm looking for people to argue with me on this one, I think we're still in a bit of a challenging time. We have effect sizes that are disappointing. Recurrence is still high. We have a high placebo response, high spontaneous recovery rate. So what is it we're treating? What should we be treating again? What should we be treating? And then we have about 30% of youth who don't respond to any treatments. That's higher among youth who've been exposed to adversity, so that's an important factor. So just to throw out some of the things that we're doing, and we're really looking, we being those that are applying what we're learning from you, what we're doing is we're beginning to look at new care pathways. We're trying to do our screening and our evaluation, and as soon as there's any suicidality that presents, and that is true for, I would say, in my experience, 70 to 75% of the depressed kids that we see, we're beginning right away to do a CAMS, collaborative assessment, and management of suicidality, a brief intervention so that we can understand better what's driving the symptoms for that particular, the suicidality for that youth, and targeting it directly right away as quickly as we can. And then we're using, really, I would say, a common elements approach where we're using some BA, some IPT, some CBT components, depending on what we've gotten in that initial assessment is what's most important for the student. And then we're moving to DBT for those that have persistent and recurrent problems. And certainly, these kids include many of the kids that Ted was talking about, and we have a mixed, we have depression as our kind of doorway in, if you will, but they're a very mixed group of kids. And then the other thing that we're really doing is enhancing our parent training, particularly for the parents of adolescents. So I'll just leave you with one kind of challenge and closing thought. So to change the paradigm of how we're doing our work clinically, we need huge support from you in terms of a strong database, because we need to rethink how we do our own work, how we go into a clinical setting and work, how we train our trainees. And that is not just our trainees in our clinical psychology programs, but I'm in a psychiatry department. It's the psychiatry residents, it's the social work students, it's the master's level mental health folks. And that's a tough hill to climb. That's a steep hill to climb. How we educate our consumers and how we shape healthcare models and fiscal reimbursement systems. So I'm hoping I'm giving you things to talk about and things to think about. Thank you.